Welcome to MedAxiom HeartTalk, where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
Hi, I'm Melanie Lawson with MedAxiom HeartTalk, and today we are honored to be joined by someone at the forefront of innovation in cardiac care and advanced life support, Dr. John Mehall. Thank you for joining us today. So Dr. Mehall is a retired cardiac surgeon with decades of clinical experience and now serves as the president of Integration Health and senior vice president at Heart Vascular Partners. While his surgical work saved countless lives in the OR, his focus today is transforming how hospitals across the country deliver life-saving care outside of that hospital. So give us a little bit of idea about what Integration Health covers.
Sure. So Integration Health is a national platform that's expanding the use of extracorporeal mechanical support. And so that can include ECMO, shock therapies, perfusion, and normothermic regional perfusion. And the growth of extracorporeal support over the last 10 years has been explosive, and we're realizing just the real impact it can have on saving lives.
All right. So let's delve a little more into ECMO and why that should be something that cardiac programs care about.
Sure. So a few people realize that ECMO has actually been around for over 50 years, and it was very slow to be adopted into 70s, 80s, 90s, and it was really in the pediatric world. And then around the 2000s, we started doing it in adults, and in the last 15 years, we really perfected the use of it in adults. And so now it's an integral component to like a complex cardiac care program, because you're going to have cardiogenic shock patients that would be ECMO candidates. You're going to have cardiac surgery patients that would be ECMO candidates. And the ECMO really serves as heart-lung support as a bridge to either a definitive intervention, like maybe a stent placement or something, or to recovery of the heart and lungs.
Okay, so ECMO is known for being complex and resource heavy. So let's talk about maybe some of the challenges that your team faces getting these programs off the ground, and how do you navigate some of those challenges?
Sure. I think the myths around ECMO have always been that it's too complex, the hospitals lose money, and that everybody dies.
Okay.
And we've really shown that that's not the truth. If you look at the database now, almost 70% of all comers survive ECMO. And if those patients survive the first 24 hours, 86% of them are going to survive to either discharge or from the hospital. So the survival data is there. We've really learned how to use the technology. The economics are there to support it. If it's done correctly, it's very profitable for the hospital. And I think the technical expertise, we've grown tremendous amount. I've been around the ECMO for 30 plus years. And our knowledge of how to use it, when to use it, and the staff and training those people to support those patients has expanded greatly.
Let's talk a little bit about that, because if the myth is that it's dangerous, how do you overcome that when trying to get hospital systems to consider this?
Sure. No, I think that's right. I think the hospital systems who try and do this on their own, where they say, oh, we're going to grow organically, we're going to do maybe 5 cases this year, and then the next year we might do 10. For those hospitals, it's almost like Groundhog Day. Every time they go to do it, they've kind of forgotten what they learned the last time. And it is difficult to get that institutional knowledge and that expertise. And one of the things that we do is we'll come in and set up this program, and then we will do everything in the very beginning. We'll take 100% care of all the patients, and then we will start to train their staff internally and then transition to care from the hospital's team. And so they can go from 0 to 200 miles an hour immediately, and they can build institutional knowledge and expertise, and then it's much easier to hand the program over to them when it's up and running smoothly.
How long does that usually take?
That usually takes 12 to 24 months, depending on the volume of cases they do and how quickly they can identify the right people to train and ramp up.
Right, better than chipping away every year and like you said, forgetting what they've learned. That's a waste of time and money.
Yeah, it is. It's a very big burden for hospitals to try and train a lot of staff people who then might not take care of a patient for 3 or 4 months, and when that patient does come along, they're maybe not so comfortable and little, like, I can't remember everything about it, and I'm afraid to take care of this patient. And I think that becomes a barrier to growing the program.
There's a lot of talk about ECMO and NRP being life-saving but underutilized, kind of where we're going with this conversation. From your perspective, what made these technologies worth investing in for hospitals or systems?
I think it's just the impact they can have for the patients. We talked about the survival rates. Well, we're really doing about 20,000 ECMO cases a year in the United States, more or less, which is double what we did in 2015. Okay. But if you look at all the indications between respiratory failure and heart failure, which are both growing at 10+% a year, you've got 500,000 people showing up in the ER with cardiac arrest that could be treated. You've got pulmonary embolism. You've got inpatients who are having, cardiac arrest or cardiopulmonary arrest in the hospital. All those patients together, that's probably 1 million patients a year. And not every single one of them is going to be a candidate, but a large majority of them are going to be candidates. And if you look at each of those indications, the outcomes and the survival are better if they're put on ECMO in almost all cases.
Yeah, wow. All right. So you talked a little bit about staffing and making sure that people were trained for this. What are the big hurdles that you see in ECMO programs, which you did touch on, but maybe an example of a team that really approached these challenges and it did work well for them?
Yeah, sure. I mean, there's a couple that come to mind, and we've gone in and started programs, we've trained their staff, and then been able to successfully hand that program over to the hospital, who now has their own internal staff who have expertise and knowledge and can run and manage it on their own. Mm-hmm. And we've done that reproducibly. We start about one program a month all across the country in 23 states now. We do quarterly education for their staff, for their medical staff, not just the nurses. We also do outreach to identify referral sources in their region that would potentially send them patients. And that keeps everybody competent. It keeps it front of mind so people know what kind of patients are to look for and would be good candidates, both in their hospital and in their region. And that all helps to drive the volume of there and keep the competency high because they're seeing patients on a regular basis.
Is there a time when maybe you're not even needed because there's enough people who really do understand it?
100%, yeah. So some programs choose to keep us there because the ECMO census variability is very high. And if you have a medium volume program, you may go 2 months and then you may have 2 or 3 patients. And it's very hard for hospitals to maintain enough staff expertise for those high census periods when they have gaps in between. They're comfortable managing 1 or 2 patients, but then all of a sudden they have 4. And so we maintain a deep bench of ECMO specialists that we can deploy across the country, and they would typically arrive in 12 to 24 hours to then take over the care of that patient. And so then we would cover that patient throughout the duration of the ECMO run until they came off of ECMO.
Yeah, it takes away some of the fear of what if.
Right, that's right. Because some of the hospitals will have somebody, and then all of a sudden they realize, oh, Thursday night and Friday night aren't covered. What are we going to do? And they can pick up the phone and we'll deploy specialists and they will go in and cover those patients either for just those shifts, or they could assume the whole care of the patient until the ECMO comes off.
So for hospitals or teams who are considering launching or expanding ECMO or NRP services, what advice would you give them to kind of get the ball rolling on this?
I mean, I think you have to have some physician champion and you have to have a core group of people that are excited about doing it. All these programs, require a physician champion and enthusiasm within your hospital to do. The implementation is not terribly difficult. Most centers that are doing high-level critical care can and should be doing ECMO, and if they're doing complex cardiac care and STEMI programs and things like that, it's a very easy extension. ECMO programs are much easier to set up than stroke programs and some of the other things that a lot of these hospitals already have. And I think there's a lot of financial tailwinds around ECMO. It's one of the highest reimbursed things in the whole DRG catalog. It doesn't have a global fee associated with it, so when it's coded and charged correctly every day, there's a billable event. And it's very meaningful to the hospital's bottom line.
Yeah, I smile when you mention champion because I've heard that so much today. When you're talking about launching anything new, is you need someone who's like, I can be the expert in this area, or at least get you to the expert. What does that champion look like? What type of qualities do they possess?
I think they possess a true internal enthusiasm and conviction that this therapy is going to save lives in their hospital. If it's the administration's idea and they try and tell the doctors to do it, it's not going to go well. But if you have someone who says, we need ECMO, we are going to save lives in our community with this therapy, then that's the person who you really want to get behind and give them all the support they need to make that a reality.
Perfect. All right. Dr. John Mehall, thank you so much for joining us on this Heart Talk.
Yeah, my pleasure. Thank you for having me.